despite what the University of Instagram tells you, all cases cannot be treated by laser gingivectomy. And that is the truth. 4 or 5 years down the line, when there has been enough time for that tissue to relapse, what happens is they'll come back with that persistent inflammation. And actually, the management of it is much more complex now. If you're going to remove an extensive amount of bone, and you might even cause mobility in that tooth, it's probably not indicated in that situation, yeah? If your alveolar bone all of a sudden grows from incidental peaks to a really low trough on the mid-palatal, the soft tissues will not be able to follow that margin there, okay? And even if you cut them to that, post-surgically, there will be rebound. It's kind of like, the way I describe it is like...
When you think of crown lengthening, what do you first think of? Do you perhaps think of aesthetic crown lengthening? That's when we're trying to make the gingival levels match up. For example, a lateral incisor, we want that gum to go a little bit higher. So that's aesthetic crown lengthening. We're lengthening how much tooth we're showing for the primary benefit of aesthetics. The other type of crown lengthening, which I personally have more experience with, is functional crown lengthening. Think of an upper premolar, which is the example we use deeper in this episode today. And this premolar has got good amount of buccal tissue, but palatally it's got very little tissue. It might even be broken subgingivally. And yes, in this world of implants, there is a place for titanium therapy, but I like to save teeth where possible. And if the general endodontic prognosis is good, a good way to improve the restorative prognosis is by doing functional crown lengthening. And so this will be necessary because yes, you've got good tissue buccally and you can get a good ferrule. Ferrule is like that tooth structure that the crown can grab onto. Now, if you haven't got any structure palatally and your palatal tooth structure is broken subgingivally, how is the crown supposed to grip that tooth structure? We need at least 2 millimeters, 360 degrees, maybe 1.5 millimeters with care, but 2 millimeters is ideal in the literature. So if we can get rid of some gum palatally and a bit of bone, and then now everything heals so that you can now grab on to 2 millimeters of tooth structure. You have lengthened how much crown you have available of the tooth to be able to restore. Hello Protrusive, I'm Jazz Galati and welcome back to your favorite dental podcast. I'm joined by specialist periodontist Dr. Hiten Halai, and you'll find out the funny way which Hiten had a big role to play in the birth of this podcast many years ago. Now we discuss everything from indications and contraindications and actually get him to guide us through the technique step by step, from assessment, bone sounding, the incision and the bone removal down to which burrs you should use for the bone removal. And if you're a student or a young clinician who's never done this before, then this should inspire you to seek out more education and learn more, pick up those books or go on a course. But it'll give you a really sound understanding. And if you have a bit more experience under your belt, with a little bit of mentorship, I think you could do this. I think functional crown lengthening, if you pick your cases well, like an upper premolar, and you'll see why an upper premolar is ideal for this. And this is fun dentistry. This is fun. You get to breathe new life into a tooth, which was otherwise of poor restorative prognosis. And once in a blue moon when I get to do this, I quite enjoy it. Now, Protrusive dental pearl time. As you know, every PDP episode I give you a pearl. And if you think back to a few episodes ago, I told you about accessing through a molar before you do your sectioning of that molar for an extraction to give you more practice of accessing molars for endo. So the more you access, the more you improve with your access cavity. Now, in a similar vein, in the perio crown lengthening field, one skill that we talk about in this podcast is bone sounding. Now, I've talked about bone sounding on this episode before. That episode with Dr. Jason Smithson on ovate pontics, absolutely brilliant. Do check it out if you haven't already. And I talked about the edentulous site and how to bone sound there. Actually, bone sounding can happen around any tooth. You want to figure out where is that bone relative to that gingival margin. And don't worry if it's not quite making sense of why you do this. That's all to come later in this episode. But essentially, you want to get a perio probe. You want to go into the depth of the sulcus, and then you want to go really hard until you hit bone. And that measurement will guide you in terms of how to do your crown lengthening. And if you've never done this before, you want to get like a feel of what it feels like to actually hit bone. Because sometimes you get to the connective tissue and you think, I'm there. But actually, if you really push a bit more, you'll sink in another millimeter or two more. And that's when you've truly done bone sounding. So how can you practice bone sounding without doing it for no reason at all? Okay, so if you're doing an extraction, then I kind of regularly bone sound for an extraction because it's one of the ways I check that the patient is sufficiently numb. So whenever I'm doing an extraction, I will probe really hard with a sharp probe, buccal, mesial, distal, lingual, to make sure that the patient is fully anesthetized. And actually what I'm doing is very often I'm getting down to the bone. And so I have just done some bone sounding. So two benefits here. One, it gives you practice of bone sounding. If it's not something that you're used used to, it gives you that skill, it gives you that tactile feel or what it feels like to feel bone. So when you do a future case of functional crown lengthening, you are more likely to get an accurate measurement. And two, it's a great way to check that you've got objective anesthesia from the tooth you're extracting. For those who are watching this on Protrusive Guidance, YouTube, etc., then you would have seen a visual. For those listening, I'm hoping I described it well enough that you can actually implement this if you have an extraction today, if you're heading into work right now. As always, everything I discuss will go in the show notes. Now, very often with my guest, we explore a topic so well, and the notes that are generated, the premium notes that we create, are a lovely summary, a cheat sheet, if you like, of the entire episode. So if you're a Protrusive Guidance member, you can get that from the Protrusive Vault or under the episode in the paid section of the app. The premium notes are a paid benefit of being a Protrusive member, and you support the podcast so me and the team can keep creating wonderful content for you. So if you ever wanted to access that PDF, because maybe you're driving, maybe you're running, and you want to revisit and refresh everything, then that's why we create the PDF summaries. A lot of work actually goes into this. So head over to protrusive.app or download the Protrusive Guidance app and check that out. This episode is eligible for CPD or 1 CE credit, and we are a PACE approved provider. Now it's time to enjoy the episode. I'll catch you in the outro. Dr. Hiten Halai, welcome to the Protrusive podcast. Before we get into today's topic, did you know, Hiten, right? And we didn't talk about this before I hit the record button. Did you know that you may be single-handedly responsible for this podcast?
What do you mean?
Okay, let me explain how. Okay. Remember at that time, many years ago, I messaged you on Facebook, right? And this must have been like, I don't know, 8, 9 years ago, 7, I don't know, a significant time ago, right? Like a significant lifetime ago, to ask you about advice about you being in Singapore. I was in England, you were in Singapore, and you were one of the guys, along with Surinder, who helped me to come to Singapore, gave me everything I needed to know. And then just as I was coming, you were leaving. Right? So you never actually got to
really crossed,
literally we're on like the opposite planes, right? Anyway, so ever so thankful for all the help you gave me, right? And then anyway, fast forward like 2 years, I come back to England, and just like you got bombarded by everyone asking you about Singapore and stuff, right?
Yeah.
I felt like I was getting bombarded like daily, right? And I was on the phone call on my commute from London to Oxford, answering the same questions that you used to answer. How much do you earn? Do you need to pass an exam? Do I speak English? You remember those questions, right?
Yeah. All the usual stuff. Yeah.
The same things that I ask you, basically, right? Anyway. So that led me to create the podcast, because episode 1 was like, okay, how can I get my message out there so people stop asking me, so I can get back to listen to my audiobooks. So episode 1 was with Surinder, expat dentist in Singapore.
Yeah.
So there we are. You created this podcast.
Strong word, but no, I'm glad to be an inspiration to you, I guess.
100%, my friend, 100%. And you've been doing great, inspiring things. You're, obviously you've been a specialist for a while now. But Hiten, tell us about yourself, man. Tell us about you, your journey, and how you ended up as a periobod.
Yeah, so I think it started at dental school. Like when I was doing my undergrad training, I really actually enjoyed perio, which is a surprise to a lot of people, because at undergrad level it tends to be what people think quite boring. But I made it a point to go and kind of learn more about than just bog standard sort of non-surgical treatment and oral hygiene, and get into a bit more depth about what actual perio is and what life looks like as a perio specialist. And it is a lot more than just kind of non-surgical treatments.
Exactly. As you were saying that, Hiten, you were saying you enjoyed it, and all I was thinking was you enjoyed sticking the scaler a few millimeters deeper than earlier, and that's it really, right? I mean, but then obviously you've done your research, you are far ahead of your time. So what does an average week look like? Tell us, what is it that you do now that you wanted to emulate and what you got a dose of as a student?
Yeah, my week is different every week. I'm usually 5 days clinical, which is quite a lot, I know, but I love
5 days a week is crazy. I don't know how you do it. I mean, It reminds me of, I think, Singapore time when I messaged you. I think you also gave a crazy answer then as well, like 6 days or something. How many days were you working in Singapore as a general
I was working 6 days, and I was doing 8 to 8. I was going to work after dinner, which is not what someone should be doing. And at that point, I started considering my life, thinking, I don't know how long I could do this. And
you obviously you're coasting now. Now you're just working 5 days, normal hours, 9 to 5. So this is you're on vacation. You're on vacation, man.
Yeah. This is nothing. I mean, and as cliche as it sounds, like actually when you enjoy what you do, like it really, like the time flies, like the week goes by, and it's Friday already, and of course, I love my weekends, and that's great. I have my weekends to myself. I don't do any work on the weekends. I make that a rule, and that's my family time. But 5 days a week, I say I'm 5 days clinical, but actually in an average month, I'm probably away a week on a bit. I do a fair amount of traveling and also lecturing now as well. So, I mean, as I do more and more of it, you know, webinars, podcasts, DFT lectures, running our own courses, those kind of things. So then that kind of takes up some time as well, doing some corporate stuff, working with Bupa and things like that. So as that increases...
What about the admin though, like patient letters? Because you know, being a specialist, that's what you expect to do, right? Writing back to referring dentists, writing comprehensive letters to your patients. How do you squeeze that in? I mean, have you got any admin time like blocked out?
At the beginning, I used to come home and past 5 o'clock, I'll be here at home for another 2 hours, just finishing off the admin, the letters for that day. And I thought to myself, this is not how I can go on. Like, this is not the way to continue with my life. And it's just eating into my time, which should be my own time. So I just basically made it a point to put systems in place at the places that I work at to make sure that there's a very effective workflow whereby as soon as the patient seen me for a consultation, that letter is pretty much ready to go. And whether that means my nurse has already loaded up the letter for me, has filled in all the template bits and bobs, and then the practice manager is already au fait with how I like my letters to be done, you know, dots the I's, crosses the T's. If I'll do a final check, sign off it goes basically. What it means now is, you know, I'll have an hour for a consultation these days, be done in 45 minutes. 15 minutes is just for me to do a bit of admin, letters get sorted, and then at least by 5 o'clock I'm done. I don't have any other bits and bobs to do. So it takes time, and you need good team members and good practices which are running really well. But putting in that effort from the beginning saves you so much time in the long run.
It's a lot of pain creating that system, teaching those around you to work to it. But once it's done, you've front loaded all the hard work. Now, have you embraced the power of AI yet?
Not yet, you know.
Dude, you need to get digital TCO right away, man. Like I've been speaking to Azim, right? I got him onto it, right? Yeah. And Azim loves it, thankfully. Okay, honestly, mate, like literally, you just stick the microphone on, right, and you press play, and it'll write a letter for you, like the full thing. He'll write your notes for you. You just have to check it. So trust me, you will love it.
He's every time I see him, he's like, "Mate, how have you not got on TCO yet?" And he keeps showing me, and I'm like, "Yeah, do you know, I need to." And then it's just laziness. I've got to be honest.
It's because you've already got your system. To change a system takes energy.
Yeah, and for me at the moment, if it's not broken, I don't know.
Yes.
I
totally understand.
To fix it, yeah.
For most dentists, the system is broken. The most dentist system is broken, and that's why it comes in. So, mate, your journey went to Singapore. You came back to the UK. You did your specialist training, and you described kind of like your week. You got some variety in there. Let's talk about the topic functional crown lengthening. Okay, before we define what it is and stuff. What percentage of your month? I mean, I don't even know, like how much this is a required service, how many referrals one gets for this compared to other work like implants, soft tissue stuff. How many referrals what percentage of your work does functional crown lengthening actually make up nowadays?
Yeah, actually, it's actually quite little. It's actually quite little, if I'm honest. I think one is people maybe not having the ability to know what can be achieved with heavily broken down teeth. And secondly as well, I think in the day of implants, you know, there's always that conversation of, okay, going through surgical procedure which costs X, may or may need root treatment, may or may need a crown, whatever. At that point, the cost of all that, are we better off extraction and implant, you know? So that often has a role to play. The aesthetic side of crown lengthening, as more and more people do Invisalign, more and more people appreciate soft tissue work. I think that's where I get more of the work from. Honestly speaking, I will maybe do 1 or 2 cases a month, something like that, of crown lengthening, whether that's functional or aesthetic. Again, and it varies from periodontist to periodontist. I know a lot of periodontists do several cases a week. I know others that don't do any. Yeah. And I think also it's, even in periodontics, people will have their own subspecialties as well. People will be heavily non-surgical, people will be surgical, people will be exclusively implants now and not do any perio treatment, right? For me, honestly,
it's a niche within a niche, isn't it? You can literally make your specialty exactly what you want.
Yeah, and for me, my niche is soft tissue work, mucogingival work. I will do 5-6 cases a week, averaging one a day of mucogingival work. So that's where my passion is and where my interest is.
When you
But that's
say mucogingival work, is that recession coverage?
not just recession coverage. It's basically augmentation of gingival tissues of any kind, not just management of recession. It's for gaining of keratinized tissue. It's for development of keratinized tissue around implants. It's around, bulking pontic sites, getting ready for bridges, those kind of things. It's a whole host of sort of procedures, basically, but all to some degree involve augmentation of soft tissue in one way or the other. But yeah, functional crown lengthening, obviously, and crown lengthening in general is something that we learn quite extensively in our perio training. And even though maybe I don't do as many as I don't do many on a day-to-day basis, it's still something that I have a good amount of knowledge on and have had experience in managing, and even complex cases and things like that. So
for the students that are listening and the younger colleagues, what are the different types of crown lengthening? What is it? Just the bare bones, like you're talking to someone who's very early in their career, just describe in simple terms, what is crown lengthening? What are the different types?
So basically, crown lengthening is a procedure. It's a surgical procedure that is carried out, and it involves augmentation of the gingival tissues and also the alveolar bone. And in that process, what we're trying to do is expose more of the tooth structure, essentially, to move it more supragingivally. And that will take many different forms. Either it involve cutting away tissue, moving tissue down. It may just involve removing gum. It may just involve removing bone, or it may involve a combination of both, basically. But essentially, it involves augmentation of either or both of those tissues to increase the crown height, essentially.
And you're doing it for aesthetics versus function, two different concepts, right?
Yeah. So when we talk about functional crown lengthening, it specifically relates to doing it for a functional purpose. That may be like,
which is always improving restorability, surely, right? Is there any other functional purpose?
Essentially, it's in the sense that you want to gain clinical crown height of some degree. Either that's to increase retention of an indirect restoration, you need to create a ferrule of some sort, or you don't have enough crown height to get a ferrule. If you've already got, or if you've got a cavity basically and it's quite subgingival and you can't get isolation there, you could carry out crown lengthening there to make the margin supragingival, to make it, one, easier for you to restore, and then long term easier for the patient to manage and maintain, so they can access that margin to clean it. Also, rarer things like, if you've got cervical resorptions, root resorptions, just apical to the CEJ, you can crown lengthen that site in order for you to restore it with a biocompatible material, and then put the tissues back over that area, basically. So that in itself is some form of crown lengthening. It's different to aesthetic crown lengthening, and just like that, aesthetics it's all about kind of improving the appearance of the smile. And most commonly, it's reducing the appearance of a gummy smile, or what we'd call a gingival excess. Tends to be patients post-ortho who then want to have kind of the gingival tissues recontoured in order to get a good amount of clinical crown height, so that when they're smiling, they show a sort of, let's say, harmonious amount of tooth and also soft tissue as well.
And get that nice gingival symmetry going as well, basically.
Yeah.
And I'm seeing more of, and you kind of alluded to it, right? In some instances, it may involve, removal of bone, or sometimes just soft tissue. Now, if you go down that approach, now I know we're supposed to be talking about functional crown lengthening, but just for a brief second on aesthetic, we see on Instagram, I just lasered the gingiva a bit and then I did some edge bonding, right? And we see that all the time, that virtually every case. I just lasered about 1 millimeter of gum. Should it be as prevalent as it is, basically? Because I don't know, I just feel as though, from my perio knowledge and understanding, that there's very few patients that will fall into a category that are amenable to that. But you explain your view when you see that.
Yeah. I teach these courses very, very regularly on crown lengthening, right? And we have one slide that relates exactly that, and it says, despite what the University of Instagram tells you, all cases cannot be treated by laser gingivectomy. And that is the truth. There will be 5% of cases which will be okay if you take 1 or 2 millimeters of gingival tissue off and you put a composite margin there, right? The reality is, the problem with that is, over time, if left long enough, it will relapse. And in the best case scenario, it will relapse with maybe a minor aesthetic issue, and you'd have to cut it back again and redo it. In worst case, if you encroach on biologic width by you cutting away tissue and you're now placing a restorative margin in an area where it shouldn't be, you're going to invade something called the biologic width. which we'll talk about in a little while when we talk about how to assess for crown lengthening. But if you're doing that, essentially over time, that patient's going to get persistent inflammation. If that's left, you're going to get pocket formation, bone loss, and eventually affect the prognosis of that tooth. So,
do you see this in the clinic, like patients coming in where they've been subject to this and they had these veneers placed and you're having to correct the crown lengthening? Tell us about these kind of cases that you might have seen.
Yeah, so exactly that. Like often what you'll see is with the laser gingivectomy, you'll see an immediate post-op where it looks all nice and clean. The laser or the electrosurgery, let's call it, because it's not actually lasers people are using, it's electrocurettage. They'll give you hemostasis, so you can put a beautiful composite restoration there, right up to the gingival margin. But the reality is, 4 or 5 years down the line, when there has been enough time for that tissue to relapse, what happens is they'll come back with that persistent inflammation. And actually, the management of it is much more complex now because they'd have to go through a retrospective crown lengthening procedure. And at that point, I can't guarantee that, let's say, those margins, which were supposed to be just sub or equi, are now not going to be exposed. And in this case where you've got high smile line, where it's really aesthetically, an issue, patients have to be warned of the risk that not only will they need a surgical crown lengthening, they may also need to have all their crowns and veneers replaced. Because as much as we try to kind of control where the final tissues will sit after crown lengthening, we don't know what's going to happen with the biology, and there's always this risk that it will inadvertently expose a margin of a restoration, which then will need to be replaced. And if someone spent a good amount of money getting it all done just a few years ago, you can imagine they're not best pleased to hear that they now got to go through all this corrective work to have it done.
Now, you said that about 5% of cases are amenable to that. Describe the ideal 5% scenario whereby we should double tap it on Instagram and this is valid.
Yeah, so let's say when we're assessing a tooth for crown lengthening now, right? There are quite a few things that we need to look at. Yeah. The first thing is, where is the soft tissue at the moment? Yeah. Do we need to expose more of the crown, or like when we're talking about crown, right? So essentially the issue is that you've got a short crown for whatever reason. Yeah. Can you get away with adding composite to the edge at the bottom of the tooth? Is that going to give you the outcome that you need? Is that going to give you the appearance of the crown height? If not, then you need to be taking it away from the gingival margin. Yeah. And if you're going to plan to take away tissue from the gingival margin, you need to know where the bone is sitting underneath there. Okay. And this is where this concept of biologic width comes into it. All right. So biologic
AKA
width,
supracrestal tissue attachment. Are you proud of me?
yes, that's the one. Yes. You know it, boy. So biologic width, yeah, it's a term that gets bandied about everywhere. Oh my God, you invaded the biologic width. But let's talk about what biologic width is here, yeah, just so everyone understands. Biologic width is a fixed number. It is basically the sum or the height of the soft tissue attachment that sits above the crest of the bone, yeah. So you have your alveolar bone here. You'll have a little bit of connective tissue that will sit and attach onto the root of the tooth. And then above that, you'll have a bit of epithelial tissue, which will sit partly on root, traverse the CEJ, and then partly on the crown of the tooth there as well, okay? The total of the connective tissue and the epithelial attachment, on average, is about 1 millimeter each, okay? So then your biologic width in an average patient is 2 millimeters. So essentially, if you have 2 millimeters of biologic width, and let's say you have a sulcus, a gingival sulcus of 1 millimeter in depth, it means that from any gingival margin that you have, the bone needs to sit at least 3 millimeters away. Yeah. And let's say you've just done a gingivectomy. Yeah. So you've taken away, let's say the sulcus depth, you've taken 1 millimeter away. So now you don't have any sulcus. You're left with just the biologic width element of it. Okay. If your bone is just 2 millimeters away, your body's going to want to recreate a new biologic width, because the biologic width is a protective mechanism. Yeah, it protects any bacterial ingress so it doesn't go on directly onto the bone. And so if you cut away a bit of gingival margin, what will happen is your body will be like, hang about, this is not right. We need to reestablish a biologic width. So it will do what it needs to. It will resorb that bone, create 1 millimeter space so that that biologic width can be shifted down 1 millimeter and allow space for a new gingival sulcus to form.
So essentially, some perio will happen in that scenario to re-establish 3 millimeters away from the gingival margin.
Correct. Now, the problem with that is you can't control, you're not in control of how much bone that's going to be changed by. Okay. So if you're lucky, it might not be that significant and it might not impact your overall outcome. Okay. But the chances are what will probably happen is over time, you will get inflammation because in the body's attempt to try and recreate that biologic width, if it can't do so, it will respond by getting inflamed and it will respond by creating pockets and then moving that bone down. Over time, you'll get recession. It will expose the margin there as well. Okay.
At the very best scenario, I guess what would happen is that the gingiva will just creep down and relapse, like you said. And if it's just an edge bonding case, that restorative material wasn't placed there, is all that happens that you lose the final smile. Yeah, you made the tooth longer and it looked amazing and symmetrical, but then a year later, it's the gums crept down and all your moments of work are gone.
Correct. You get relapse basically of it, right? Mm-hmm. That's best case scenario. Worst case scenario, you've got a margin that's stopping that tissue from rebounding. So then essentially, it's always going to be an issue unless that restorative margin is removed. Yeah.
Okay. So moving on to functional, if you don't mind.
Yeah.
Just I want to know the differences, the nuances, and if you assess it the same way for functional, but then also about which teeth, eventually we'll get to it, which teeth are amenable to it.
Yes. So generally teeth that are amenable to functional crown lengthening, all teeth, generally speaking, you can do crown lengthening on molars, anteriors, premolar and stuff. But there are certain things that we need to consider, which are like kind of contraindications to doing crown lengthening. Yeah. So let's say basically you need to look at a couple of things. You need to look at whether at the end of your treatment, you're going to have enough root length left in the alveolar bone. What I'm alluding to here is, are you going to end up with a favorable crown to root ratio by the end of the crown lengthening procedure? Yeah. If you're going to remove an extensive amount of bone, if you're going to have a very little bit of root left, that the prognosis of that tooth, and you might even cause mobility in that tooth, is probably not indicated in that situation. Yeah. The other thing is root proximity. So particularly in posterior teeth, if you've got two molar roots which are very, very close together, this is a practical contraindication. In functional crown lengthening, it requires you to remove interdental bone. And if you haven't got enough space between roots to get even a piezon or a burr or even the smallest rose head through there, you're going to cause iatrogenic damage to those roots. Yeah, again, it's going to affect the prognosis of those teeth. So you just practically can't do it in those situations. Another big thing in molars is furcation exposure. Now, in the molars, furcation entrances, so the fornix of furcations can be as shallow as 1 to 2 millimeters away from the CEJ. Yeah. So that doesn't really give you much scope to crown lengthen. Yeah. And in an ideal situation, you want to keep 1 millimeter of bone above the fornix of any furcation. Okay. So the reality of it is very few teeth actually meet the ideal, let's say, indications for crown lengthening. All right. So essentially, some teeth that you crown lengthen, it may lead to a furcation exposure. But as long as you understand that that's what's going to happen, you understand the implications of that, and your patient is consented of that. Because essentially, if you've got a furcation exposure, yes, it will impact the prognosis of that tooth long term. The patient will have to maintain that site. You will have to continually check that area as well. But the alternative could be an extraction of that tooth, which the patient may not be wanting.
But, going back to your previous point, if you're getting to a scenario where you're crown lengthening a molar for functional reasons so that you can restore it, likely, again, this tooth already has or will need a root canal, need a temporary crown, a crown. Just like you said before, you're getting into implant territory. So it's something that I can see why molars are anatomical complexities, access, and the cost is not something that I've ever done. I've done premolars. It's the only time I've ever done crown lengthening is premolar. I just tend to get premolars that I think, I fancy, improving the prognosis of this tooth. Because even with incisors actually, I had a patient who had canine to canine wear that was more on the palatal, and that had enough ferrule labally, but I didn't have enough ferrule palatally, right? And so by getting more palatal tooth structure, I was able to get a ferrule 360. So those are two scenarios I've done it. Is that what you're suggesting as well? Is the more common way to go?
Yeah, I mean, another common thing is when you've got subgingival fractures, let's say premolars, right? And you've got cuspal fractures. Those are kind of good candidates for crown lengthening, which, you'll see palatal cusp fracture. I mean, crown lengthening palatally is much easier than to do buccally, which you think, okay, access wise, it's easier buccally, but actually palatally, you have ample alveolar bone, you have ample keratinized tissue, and keratinized tissue, another big factor that we need to talk about. But when you are first starting out, those are the kind of ones that are a bit more easier to do and a bit more forgiving, because
which is why I cherry pick those.
yeah, because
All the tough
honestly,
ones, I send them guys like you.
so when we talk about it, when you boil down to it, actually very few teeth are the ideal candidate for crown lengthening. Yeah. And before you get to that point, yeah, a lot of molar teeth, you'll be having that conversation already. It's like, okay, well, by the time you add the cost of the crown lengthening surgery, the crown, potential root canal that might be necessary, are you already in the point of, should we think about extraction and implant at that point there? Yeah.
Do you mind asking, if you were to crown lengthen a molar, right? Obviously, we charge by time. How long would it take you? What's the London rate or England rate in terms of, a crown lengthening for a molar, for example? The reason I'm only bringing it out is because that dentists who may never been subjected to this, they can actually involve in their calculations, have an informed discussion with their patient.
Yeah. To be honest, it varies from place to place at work. Typically, I will take about an hour or so to do that procedure. It can vary from £700 to £900 typically for a crown lengthening procedure.
Okay, so we can factor that in, and very quickly, with the root canal for the specialist, £1,200-1,300. Then the crown, it's easy getting into implant territory, basically. So that just validates that. So those teeth, like such, for example, premolars and whatnot, when you are doing a crown lengthening there, functional crown lengthening, what are you assessing for to make sure that, okay, you said already about the proximity to the adjacent tooth, about whether there's enough root there as well. What else are you doing before we then actually think, okay, I'm going to pick up the scalpel?
Right, yes. So, as I said, first I need to know, the most important thing is, where is my margin going to be? Like, where is my proposed gingival margin? Where am I going to plan to restore to? You have to work backwards. So you've got to say, look, this is where I envisage my new CEJ, my new gingival margin will be. If I cut my gingival tissue to this much, based on my biologic width measurement, I'm going to need to move my bone margin by this much. All right. And then you'll know, okay, you'll be able to assess, okay, look, will I be in a good crown to root ratio or not, that you can look at, right? So, it's basically you working backwards. You start with the final prosthesis or restoration, and then you're going to calculate backwards kind of how much soft tissue you need to remove, how much bone you're going to remove as well there, okay? When you're doing that preoperative assessment, one of the other things that is quite important, and we'll talk about, is keratinized tissue, okay? So keratinized tissue, until recently, it's been something that as periodontists is quite, I don't want to say controversial, it's not controversial, it's kind of like heavily debated about how much keratinized tissue you need around a tooth, okay? It wasn't only till 2017 when the classification guidelines came out that it's been agreed that you need 2 millimeters of keratinized tissue and 1 millimeter of attached tissue around the tooth for it to be stable and for you to minimize the risk of further gingival recession or periodontal disease occurring on that tooth.
What do you mean by keratinized, I understand, but what do you mean by keratinized and attached?
Attached, right. So essentially, if you think about the formation of a sulcus, a sulcus is not attached, it's free gingiva. When you put your probe into it, it moves, okay? Beyond that, the tissue beyond that is attached to the alveolar bone underneath, okay?
Understood.
So that is basically tissue that is attached by periosteum to the alveolar bone underneath, okay? And that is not mobile. You don't always have that. Let's say, for example, commonplace you don't have that is lower incisor labial, if teeth are really moved out of the alveolars and there's no attached gingiva, it means when you pull the lip down, all that tissue moves with it, okay? And that's not attached. So one, there has to be keratinization there, and two, not only has to be keratinized, at least a millimeter of it has to be attached onto basically the bed or the periosteum underneath that, okay? So that's why those two things have to be met. And when you're crown lengthening, remember, we're essentially planning to cut away tissue here, okay? That's what crown lengthening is. You're cutting away tissue to expose more clinical crown height. If you don't have 2 millimeters of keratinized tissue, you can't afford to cut it away.
Which is why I favored those cases, just like you said, palatally, where I didn't have to worry about that. I had enough labeling, which is why I cherry picked those cases.
Cut what you want. In palate, there's keratinized tissue everywhere. But yes, buccally, there's, if you don't have 2 millimeters of keratinized tissue, you can't cut it away, unfortunately. And therefore you get into more complex territory, which means you're going to have to think about trying to move that whole band of keratinized tissue that you do have apically. So here we're talking about apically repositioned flaps. You're getting into specialist territory, complex sort of crown lengthening. Honestly, luckily, 9 times out of 10, a tooth that you're crown lengthening, because it's associated with a thicker phenotype, will have a decent band of keratinized tissue that you can cut away. Okay.
So you can sacrifice, and you don't have to do apical repositioning. You can do excisive. What's it called?
Gingivectomy.
Resective.
Yeah, the resective surgery. You'll do resective or gingivectomy in that area, basically. Okay. I mean, worst case scenario is if you don't have any keratinized tissue, essentially what you have to do is you have to put a graft there to create keratinized tissue first, and then cut it away or move it apically, basically.
Got it.
Yeah.
Sounds like a lot of work, Hiten.
It's a lot of work, right? And that's why you can see very few people have it done. Yeah.
This is why they call it gum gardening. There we are. It all makes sense now.
So that's why it gets quite complex. But honestly speaking, 9 times out of 10, you'll have a straightforward type of case because interestingly, the other thing, so we're talking about, just coming back to the main thing, which is where we're talking about preoperative assessments, right? So one thing is keratinized tissue. The other thing as well is tissue thickness, or the gingival phenotype. You'll have two types. You'll have a thin phenotype or a thicker phenotype. People are somewhere in the middle, but broadly speaking, if you're a thinner phenotype, it's very unlikely you're going to be suffering from gummy smiles and things like that, okay? Often what happens in those situations is the tissues will recede over time. So thinner tissues, they just tend to recede, okay? So most often, let's say specifically for gummy smile treatment, you're going to have the thicker phenotype, and the thicker phenotype is also associated with more keratinized tissue and
better outcomes, better healing, less risk of recession and unpredictable healing, right?
Yeah, I mean, we say about better healing, each of them have their nuances as well, So with a thicker phenotype, your patient is more prone to rebound,
relapse.
Exactly, because the tissues will relapse. They're not going to recede, So if anything, what's going to happen is once you do your crown lengthening, I'm already thinking, okay, this patient's a thicker phenotype. So when I've done my biologic width measurement, say that my biologic width measurement is 2 millimeters, usually I will allow 3 millimeters from the gingival margin. I may allow 3 to 4 millimeters to allow for a bit of rebound to occur in a thicker phenotype. Yeah. Whereas, and I may cut away a little bit more tissue than I need to, knowing that there will be some rebound of that tissue in a thick phenotype. Okay. In contrast, when we're talking about a thinner phenotype, you're going to be much more conservative. So you're going to cut away a little bit less because there'll be some postoperative recession. Even with the alveolar bone, you'll cut a little bit less away because that as you get post-surgical inflammation, that will probably take away a little bit of that alveolar bone height as well. So you're not going to go to the full 3-4 millimeters. You maybe shy away a little bit and allow the body to do a little bit of it as well. So that again is a nuance. Like, so you're looking first at keratinized tissue. Have you got enough? If you do, fantastic, cut it, no problems. If you don't, you're going to be needing to do some kind of apical repositioning surgery, or you're going to need to be doing grafting. Bit too complex, I would say. Probably needs to go specialist at that point. But gingivectomy, with someone who's got training at a general dental practice level, is more than capable of doing that. And then you've got to look at the tissue thickness. Have we got a thick or a thin phenotype? That's going to dictate how we carry out the surgery. And also, I mean, without going into too much detail of it, the way that your blade is inclined, because you may have heard of terms of inverse and external bevel incisions, okay? Internal and external bevel incisions, right? So internal bevels are designed to thin thick tissues. External bevels are designed to make thinner tissues thicker, So those little nuances, they'll come into play when you kind of trying to plan the actual sort of the nuances of the surgical treatment.
I'd heard of those incisions, but it's nice to know the sort of role they play, and the nice little nuance to consider. In the interest of making it tangible for the GDPs that are listening here, everything makes so much sense so far. Let's talk about, I think sometimes when you talk about, because you can't cover everything about crown lengthening, that's not the point. It's about to give people a flavour, when it can be used, indications, contraindications, suitability. Have you done that already? So let's talk about a specific scenario, and we just talk about that one specific scenario. We can learn a lot more and go deeper, basically. So let's talk about the premolars that I've treated, for example. I remember treating these premolars and on the upper right, and I treated both these premolars because the kind of fracture they had was that I was really lacking palatal tooth structure. But I had a buccal wall that was decent. So because I was lacking palatal tooth structure, and I knew that keratinized tissue is important, and I still don't know how to do an apical repositioning. I was like, okay, this is a great candidate for me as a GDP. The patient can afford the endo and the restoration stuff. So, in that scenario, talk us through the sort of procedural element of the functional crown lengthening.
Right. Okay. So first you've got to decide how much crown height you want to gain. Okay.
All right. So let's say we want to be able to. So right now, if you want to put a crown margin there, you don't have any ferrule, and we want at least a 2 millimeter ferrule. So we want to gain 2 millimeters of tooth structure. We want +2 on the palatal. Okay,
fine. So we're aiming to we have a restorative margin 2 millimeters of where your current tooth clinical crown ends at the moment. Yeah. Okay. Yeah. Fine. So now we know that. Okay. Let's say palatally, you're going to have a thicker phenotype. Yeah. 9 times in 10, it's going to be thicker. Okay. So what we need to do now is from your restorative margin, you're going to want to take away at least 2 millimeters, okay? So you can get that clinical crown. I would say go 3 millimeters. So actually what we're going to plan is a gingivectomy 3 millimeters from where your current crown height is, okay? That will allow for a little bit of relapse, okay? And it will also allow for the formation of a gingival sulcus in that area, okay? It's not so crucial on the palatal because whether your margin is, ideally you want it a little bit supragingival anyway because it's cleansable, it's not really an aesthetic site. But yeah, we're talking about 3 millimeters of gingivectomy that we're going to perform. Okay?
So this is a scalpel, electrocautery, use whatever you want basically, right?
You can use you can use 3. You can use laser, you can use electrosurgery, you can use a blade, yeah? To do that gingivectomy. Now, but before you do that, we're going to be doing a pocket chart. We're going to basically do bone sounding on the palatal aspect, okay? The purpose of the bone sounding is to determine the biologic width, okay? So let's say we figured out that biologic width is 2 millimeters, okay? Yeah. So what that means is from our gingival margin, the new gingival margin that we've created, the bone has to sit 2 millimeters, which is going to be the biologic width, plus 1 millimeter for the gingival sulcus. So the bone has to sit 3 millimeters away from the new gingival margin that you've created. Yeah.
So therefore, compared to where it is now, right? You're going to go to this, but I'm kind of working out for everyone here. Compared to where the tooth is broken down now, the bone should end up being 5 millimeters away from that.
Exactly. Yeah.
Okay. And you can use stents and stuff, right?
Yeah. Well, you don't have to use stents. You don't have to use stents.
I don't. I haven't. Yeah.
No. So the time you will need to use a stent is if you're planning usually aesthetic sites when you're doing anterior aesthetics, because that's when it's really key, right? But even like just for aesthetic crown lengthening where there's no cosmetic work planned, or even just small edge bonding, I won't use a stent. If we're talking about full veneers, full composite bonding, then yes, we'll be using a stent, okay, based on the definitive prosthesis. But in these cases, palatals, it's not necessary, okay? Because in your mind's eye, you already know where you're proposing to have your gingival margin there, okay?
Yeah, you can check with your perioprobe, put it right up against the bone and see where the margin is, and you can do that calculation of when the biological width reestablishes, how much tooth structure will that give you? So it's like a game of maths, like you said before as well. The only thing that I want to check on in terms of nuances, because younger colleagues are thinking about bone sounding, right? I've covered it before in a podcast, but people don't listen to everything. So just cover in that upper premolar area, palatal, what does bone sounding look like when you do it?
Okay, so what's going to happen? You need to do it under anesthetic, because it's quite uncomfortable otherwise. So what happens is you're trying to determine what the biologic width is. That's what bone sounding is, okay? And if you remember, the biologic width is the sum or the height of the epithelial attachment and the connective tissue attachment. It doesn't include the gingival margin value, okay? Because that varies from site to site, okay? So what we're going to do, we're going to get our perioprobe and we're going to insert it into the pocket, okay? That's going to give us a measure of the gingival margin. Yeah.
The sulcus.
The sulcus depth. Yeah. So let's say we've got 2 millimeters of a sulcus at that point. Okay. Your probe is going to measure 2 on the band. Okay. From there, we're going to basically pierce through the soft tissue until we hit a bony stop. Okay. You will definitely feel if you go along the root surface, you will hit the alveolar bone, and your probe won't go any further. Okay. So now you've reached the crest of the bone. Okay. So let's say that measurement is now 4. Okay.
Yeah.
So from your gingival margin measurement, your sulcus measurement, sorry, your probe has traveled 2 millimeters further down to hit the bone. Okay. So that 2 millimeters that your probe has traveled, that's your biologic width, because you've now pierced through connective tissue and epithelial tissue to get to the height of the alveolar bone. So that's what.
And in some individuals, this could be more. This could be 3, for example, right? In some individuals, like there could be, it's an individual thing, like you said at the beginning. Some people might miss that. So from reading Coyce's work, high crest, low crest, we won't get into that. But some people there's a variation basically. So it's good to measure each individual's actual biological width, like you said.
It will vary from site to site. It will vary from tooth to tooth. It will vary from person to person. When we look at studies, it varies on humans from between 1 to 6 millimeters on average per patient. Okay. Look, you don't need to be so facetious about it, about measuring every single site and doing a biologic width measurement and then going to do that, on a 6-point. But as long as you get a rough idea of what that biologic measurement of that patient is, that's pretty good. So I will set an average value of what the biologic width measurement is on that tooth, let's say. And like I said, typically it's going to be around 2 millimeters on average. Most here or there, it's about 2 millimeters is the average measurement of a biologic width.
Here's a geeky question, right?
Yeah.
So we go with that scenario where we're going to plan to remove, in this patient, then remove 2 millimeters of bone, right? And to reestablish that. But then we also counted for the 1 millimeter sulcus. But if someone started with a 2 millimeter sulcus, should we be planning for them to have a 2 millimeter sulcus at the end, or should we still aim for 1 millimeter sulcus?
I mean, it's neither here nor there. It doesn't really matter because
it's one of those things.
Yeah, because the sulcus is again variable. Yeah, the sulcus depth. What I would say to you is, as long as you got 1 millimeter room for a sulcus, that's good. If you want to give 2, it's fine. Okay, because the sulcus will be 2 millimeters. It's fine. It's not the end of the world. Okay, but at least you need at least 1 millimeter is what I would say. Yeah.
Okay, so you've done the gingivectomy there. Before you've done the gingivectomy, you did the bone sounding, your measurement. You've done the gingivectomy, and then...
Just come back to the gingivectomy. Now, the shape of the gingivectomy is also quite important as well, okay? So when we're talking about functional crown lengthening, it's very rare that it just involves let's say, the palatal, the wall of the tooth. We have to also include the interdental spaces. Yeah.
Yep.
So it can't just be a case where the incision is just done like a little C shape,
U-shape,
or U shape. No, it has to gradate. It has to taper and to include the papilla. Okay. So it's what we call like a crisscross design. So you're basically from the midpoint of the palatal aspect of that tooth, you're going to go and include the papilla on one side and the same on the other side. Okay. So what that means is when that flap is elevated and you go and remove the bone, not just on the palatal aspect, but also in the interdental space, when the papilla sits back down, you'll have created crown height in the interdental area as well. Yeah, you can't just do it in isolation. Okay. And again, the other thing with that is you have to end up with what is called positive architecture. Yeah. And this is more important for interdental crown lengthening. Actually, let's leave that aside for a second. Let's just kind of focus in on what we're talking about here.
Because you're a specialist, man. You're like every little nuance detail, which I love it. You could definitely see that coming through.
I need to tell you about negative and positive architecture. But you told me to keep it simple. So let's keep it simple. Let's go back to where we were. We were talking about the incision, which has to not only be palatal, it has to include the papilla. So that's what my point is.
Very useful. And the take-home point there is don't neglect the interproximal, because even if you don't need mesial and distal ferrule, let's say you have that by chance and you just only happen to have like the palatal, mid-palatal portion, for example. Rare, obviously, but even still, you need to account for some bone removal, mesial and distal, because you can't just have like a crater which is I think what you're trying to get to. You can't have a crater down the middle and then you need a nice transition. So this is why I learned when I was doing my first few cases, I was learning about this, of making sure that the bone is smooth and flowing. And from memory, it was like there was a certain number of degrees. Was it 15 degrees or something like that? Like it shouldn't be like too acute. It shouldn't be like a step.
Yeah, 15 degrees roughly. But what we're saying here essentially is soft tissue do not like sort of very steep curves and very quick changes in its
Bony
architecture
contour.
underneath. So
Yeah.
if your alveolar bone all of a sudden grows from incidental peaks to a really low trough on the mid-palatal, the soft tissues will not be able to follow that margin there, okay? And even if you cut them to that, post-surgically, there will be rebound. It's kind of like, the way I describe it is like kind of two curtain poles, right? Or two tent poles, right? If you've got two tent poles hanging really tall, yeah, and you're draping a fabric over it, that fabric is not going to sit with a big deep V in the middle there, okay? It's going to sit up there, okay? You're not going to get that shape, that deep U shape that you've cut away. It will just rebound and it will be held up by those incidental bone peaks. So that's part of the reason why you have to remove those incidental bone peaks to some degree in order for you to get that undulating pattern of the soft tissue to stay where it is at the position that you cut it to, basically on the incidental, on the mid-palatal portion. Yeah.
Brilliant. So that's a little a clinical tip there to bear in mind when you're thinking and planning in your head as well. So once you've done the gingivectomy, the kind of flaps I've done in the past, rightly or wrongly, have been envelope. Like I just lifted away. I didn't do any like relieving incisions or anything because palatally I just didn't feel I need to. Is that how you do it as well?
Yeah, the only time you'll need to do a relieving incision is if you're going to do an apically repositioning of that flap. Yeah. When I teach these things and we do the practical element, people will say, have I extended it too far? Have I raised the flap enough? And my answer is, why have you raised that flap in the first place? And the answer is, well, you've raised that flap because you want to access the bone. Yeah. Because if you because otherwise you'd have ended at the gingivectomy. That's all you would have had to do. The sole purpose now of raising a flap is to access the bone underneath so you can adjust it, okay? And if that was the purpose of what you intended to raise that flap, can you do your job? Can you get an instrument in there? Can you see the site that you need to remove the bone from, and can you do it safely? And if the answer to that is no, then you haven't raised your flap enough, right?
It's all about access.
Yeah, because you can't access it, and that's the only reason you raise the flap now. And so in order to get more access, you have to extend the flap laterally, yeah? So increase the envelope. So it may mean you have to include then the neighboring papilla on either side. Yeah. You very, very rarely, in fact, you'll never need to do a vertical incision there, okay? You just extend it laterally. It's better to do that because you'll get better healing. Not only better healing, as soon as you start dropping vertical incisions on flaps, you completely lose the mobility. You'll increase the mobility dramatically, let's say. So you completely lose the stability of the flap, okay?
I knew that. That's why I felt comfortable as a GDP with some experience and some prior homework and whatnot to do these procedures, because I felt, okay, I'm in a safe area where I don't need to do any relieving incisions, and that worked well. So once you got your envelope flap, you can see the bone. I remember many years ago when I did this, I picked up the phone to Drew Shah, the periodontist. I said, Drew, what kind of burrs can I use on the bone, right? And he said, dude, just use carbide, use diamond, use what you want. I was like, really? Is there a special bone burr? Like, like as a GDP, I didn't know. So tell us about the kind of burrs you're using.
So I would just use a sterile rose head, straightforward. Yeah, you're gonna have some kind of irrigation through it because it has to be cooling. Yeah, but it doesn't have to be anything fancy, man. Like, honestly speaking, it's not unknown that I will use an ultrasonic to remove alveolar bone on a higher setting. If the bone is so thin, you can chip away at it with an ultrasonic and then get a curette just to scrape it off. If it's thicker, you just use a slow speed rose head. Fine, not an issue, okay? Yeah, you can use lasers. Yeah, you can use Pisons and things like that. But in general practice, if you've not got access to those things, slow speed with some kind of irrigation, or even if you don't have irrigation, you'll need to have your nurse kind of doing saline through it. That's absolutely fine. Usually on our courses, we teach people to use ultrasonics to chip away, because when you're talking about aesthetic sites, the bone's a little bit thinner. So you can get away with marking out where you need to be with ultrasonic. And then actually, if you use ultrasonic on alveolar bone, it creates like this kind of mushy kind of texture, which you can then just scrape away with a curette. You actually get a decent amount of control with an ultrasonic. So sometimes I'll just ultrasonic. But yeah, rose head's absolutely fine. Yeah, that's what I tend to use in most cases.
To help the beginners out there, when I did this, having some mentoring with, Drew or Amit Patel, whoever was helping me at the time. Yeah. Once you remove the height of the bone, like at 2 millimeters, it's really important then to make sure you smooth that step, right? So if you've gone down vertically, if you feel with your glove finger, you'll feel like a step bone. Again, your earlier point earlier, as you said, everything needs to be smooth and flowing. So again, is that something that you would use the burr for, or some sort of specialized chisels and stuff? Files?
Either. Again, either. Yeah. You can either use a chisel, you can use a bone curette, or you can just use the rose head again. Yeah. All you're trying to achieve is, so like, to liken it to a crown prep, you try to go from a shoulder to a chamfer, basically. Yeah. Because again, it comes down to the fact that the soft tissue does not like those steep changes in, or acute changes in, the underlying bone architecture. Okay. So if you were to leave this little ledge there, essentially, or the shoulder, you'll end up with this weird, like, kind of trough or pocket. It will form into a pocket, basically, and the soft tissue won't be able to adapt itself well into that area. Okay. And, at worst, it'll leave a pocket, but in anterior site, essentially, you'd have a weird aesthetic result. You won't have a nice emergence profile of your tooth from the gingiva, because it will have this little bulky appearance, and then the tooth will come out from there. So you do kind of like a chamfer, you kind of gradate that in a horizontal direction as well, so that the soft tissues can adapt better into that area.
Brilliant. Now, in the interest of time, and obviously there's only so much we can discuss, and I'd encourage everyone to attend your courses, attend some perio training. It's always good to add these skill sets to your GDP. Skill sets, it gives you an appreciation of the surgical techniques, and also be able to restore teeth that you may not have been able to restore before. It's a great little thing. I've got a case coming up in a few weeks' time, again, a premolar, palatal side. I was like, okay, yeah, I've been here before. I'm a great, best thing about being a GDP, Hiten, the ability to cherry pick, right? And I think case selection is everything, and you must hate that. But now you're on the other side, right? But in the interest of time, look, we're not going to go into the suturing. We're not going to go into this. The main question I want to answer now, because I want them to learn more and get inspired to learn more. But the main question is, how long to wait before you can actually put your definitive restorations?
Okay. All right. So generally speaking, let's just first talk about evidence here. Okay. So 80 to 90% of the healing will occur within the first 2 months. Okay. So what's happening here is you're getting epithelial and the connective tissues reforming, periosteums reforming, and you're going to get maturation of the tissue just starting at the 2 months phase. Okay. So basically what that means is 80 to 90% of the stability is there at 2 months. Okay. But after that, you can get some minor changes. Okay. So the gingival margin may creep up a little bit or go down a little bit. We're talking maybe 0.5 millimeter here or there. Okay. So what I would say is, in a posterior site where the final gingival margin, if it's gone up 0.5 mil, 1 mil max, it's not going to make that much of a difference. 3 months. Yeah. Anterior sites where we're talking really highly aesthetic work, and gingival margin, it has to be spot on. I would say wait at least 6 months before you go on and do your definitive restorations. So during that time, the patient will be in temporaries, and as the soft tissues change, you can probably be, you need good lab-made long-term temporaries, and you can be adding composite onto the margins as and when you need to, but definitely plan and consent your patient to accept the temporaries for at least 6 months. Okay. And also when you're doing your planning, that's what you want to be doing if you want to get a nice, stable result and a good aesthetic outcome for your patients.
So in our scenario of the example premolar, it's like 3 months will be fine for that, because the palatal gingival margin moving here and there is not so crucial.
No, yeah, even 2 months,
2 months.
2-3 months, I would be fine on the palatal aspect, because I said, the main aim there was to get enough clinical crown height there, yeah, and you pretty sure, if you're going to keep your margins quite supragingival, which you probably will do in a palatal, if they creep up by 1 millimeter, it's not the end of the world. Yeah, because you still pretty much will be supragingival. Yeah, but in a aesthetic site, that 1 millimeter could be a massive difference.
Absolutely.
So that could be the difference between an exposed margin and a hidden margin. So
very true. Each case on its merit, and it's all, like you said, it's all in the planning. Hiten, thanks so much for giving us this tour. We reached a 1 hour point now of time goes fast, doesn't it? Time flies when you're having fun. Functional crown lengthening. We talked a little bit about the aesthetic crown lengthening in the beginning, how be careful with that, quote unquote laser gingivectomy, and we talked a little bit about the biological width, therefore. Then we talked about these scenarios of doing functional crown lengthening, the nuances of it. We almost got super duper geeky and talked about all these positive, negative stuff, but I really back in. I had to really back in, and we covered it quite nicely there. Yes, we didn't talk about suturing. Yes, we didn't talk about post-op care protocols, but this is all to inspire you guys to learn more, to gain your CPD for this podcast, which is great, but also just you get a higher level of understanding, and hopefully we made this topic a bit more tangible for the dentist. Now, how can we learn more from you? I know there's some training that you do. Tell us where to find out more.
Yeah, basically I'm involved with an academy, EduDent, and we run courses for GDPs, not just GDPs, we also run courses for hygienists and therapists as well. But, on the basis of this, if you are interested in learning more about crown lengthening, if you want to learn about when and when not you can be doing the gingivectomies, to doing the more complex types of cases and aesthetic cases, and you want to know the proper protocol that we as specialists follow to get predictable outcomes, then you can sign up to our course, and you can find our details, which is EduDent UK, that's EduDent UK on Instagram, or you can go onto www.edudent.co.uk. Also, if any of you guys want to know a bit more about crown lengthening, about getting started, feel free to just drop me a message. You can contact me on hh_periodontics, which is my Instagram as well. Or you can email me, info@hhperiodontics.com.
Instagram, follow him. It's how,
Yeah.
I think it must have been Facebook Messenger back in the day when I was messaging you, is how you helped me with my Singapore move, which led to this podcast being created. So there's good things that can come if you need some perio advice, and Hiten's your guy.
Yeah. I'm happy to give you guys, even if you just want a second opinion on anything, even if it's not crown lengthening, just drop me a message. You want to know about referrals, whatever it may be, I'm approachable.
And where do you work? London, yeah?
I work all around. I work in London, and I work in Berkshire and in Hertfordshire.
Whereabouts in Berkshire?
I work in Windsor, in Burnham, and in Chalfont, St. Peter.
You sound like an endodontist, man. You're everywhere.
I know, man. Yeah, I've got to keep myself on my toes, isn't it?
Have you ever turned up, one of our guests once, Amir Ali Bokas, he turned up at the wrong, because he worked at so many clinics, he turned up at the wrong clinic on the wrong day. Has that happened to you?
Once. I can't believe I did that. I'm usually so organized, but once I rocked up to clinic and they were like, "Hey, you're not meant to be here." And I was like, and I quickly led it. Luckily, it was between Burnham and Windsor, and it's 20 minutes away, so it was fine. But yeah, imagine I was on Harley Street and I needed to get in Windsor. So half the day.
That's a day gone.
But no, thankfully it's not happened that much. Yeah.
I always wondered how you guys manage it. Well, there we are. It's nice to get a glimpse into specialist life as well. Hiten, thank you so much for all those years ago helping me, but also today helping make functional crown lengthening tangible, and we gained a lot from that. So thanks so much, my friend.
No worries. Absolute pleasure, Jess.
Well, there we have it, guys. Thank you so much for listening all the way to the end. As we went on, we made it more and more tangible so you can really visualize what a functional crown lengthening looks like, even if you've never done one before or never seen one before. Thanks again to my guest, Dr. Hiten Halai, for both inspiring the birth of the podcast, if you like, and also talking us through functional crown lengthening. Now, if you've never done anything like this before, you've never actually made an incision, then please go and sort of perio training, read a book about perio, see some videos on YouTube, do what you like. That always inspired me before surgery. And maybe if you've got a few more years under your belt, you're confident with sectioning and elevating, and you've got a nice case, then with a few questions, and maybe you can post on the Protrusive Guidance app, send us a radiograph, send us some photos, and ask questions. Whilst it's not one-to-one mentorship, our group mentorship on Protrusive Guidance is absolutely brilliant. We have some real superstars on there, some lovely, kind, geeky dentists that are so generous with their knowledge. And I'm so proud to have created this community. So if you're not already part of the community, do join us. The website is protrusive.app. And if there's one thing you do today, if you're not already a member, please join us. It's a bit of a selection process. We are approving. We have to verify that you are a dental professional, because this is how we keep our platform secure and nice and geeky and allow ourselves to be vulnerable. Because when we do that, we unlock so much more learning. Thank you so much once again, everyone. I'll catch you same time, same place next week. Bye for now.